Hey everyone, I am Evelyn Nansang, and in this video, I will talk about phagocytic dysfunction. If you want to know more about phagocytic dysfunction, then just keep on watching. Here are the things that you need to know about phagocytic dysfunction. First is its definition, etiology, pathophysiology, diagnostic procedures, signs and symptoms, complications, nursing diagnosis, managements, medical managements, and prognosis. Before we start about phagocytic dysfunction, let us have a short recap on what is phagocytosis. Phagocytosis is the ingestion of microbes or other particles such as cellular debris. Phagocytes, on the other hand, are specialized cells, primarily neutrophils and macrophages, that perform phagocytosis. Shown in the pictures are phagocytes that protect the body by ingesting harmful foreign particles, bacteria, and dead or dying cells. First are the neutrophils. Neutrophils are a type of white blood cells that protect us from infections. They make up approximately 40% to 60% of the white blood cells in our body, and are one of the first cells to arrive on the scene when we experience a bacterial infection. Second are the eosinophils. Eosinophils are a type of disease-fighting white blood cells. This condition most often indicates a parasitic infection, an allergic reaction, or cancer. You can have high levels of eosinophils in your blood or in tissues at the site of an infection or inflammation. Third are the basophils. Basophils are a type of white blood cells. Although they are produced in the bone marrow, they are found in many tissues throughout the body. They are part of the immune system and play a role in its proper function. Low levels of basophils may be due to an allergic reaction. Next are the monocytes. Monocytes are another type of white blood cells. They are the largest type of leukocyte and can differentiate into macrophages and myeloid lineage dendritic cells. High levels of monocyte may indicate the presence of chronic infection, an autoimmune or blood disorder, cancer, or other medical conditions. Next are the T cells. T cells, also called as T lymphocytes, are one of the major components of the adaptive immune system. Their roles include directly killing infected host cells, activating other immune cells, producing cytokines, and regulating immune response. Next are the B cells. B cells are at the center of the adaptive humoral immune system and are responsible for mediating the production of antigen-specific immunoglobulin directed against invasive pathogens typically known as antibodies. Next are the killer cells. Natural killer cells are effector lymphocytes of the innate immune system that control several types of tumors and microbial infections by limiting their spread and subsequent tissue damage. Lastly are the macrophages. Macrophages are specialized cells involved in the detection, phagocytosis, and destruction of bacteria and other harmful organisms. In addition, they can also present antigens to T cells and initiate inflammation by releasing molecules known as cytokines that activate other cells. When bacteria or other pathogens are present in the body, certain white blood cells are categorized as phagocytes consume the microorganisms to protect the body from infection. The process of consuming the pathogen begins when the phagocyte is attracted to chemicals from the pathogen and through receptors binds to it. The phagocyte ingests a microbe encasing it in a compartment called a vacuole. Lysosomes in the phagocyte merge with the vacuole. Its enzymes then kill and digest the pathogen and release any indigestible remains from the cell. This cell process, called phagocytosis, protects the body by removing pathogens. Phagocytic dysfunction, also called phagocytic disorders, refers to a class of medical conditions where phagocytes have diminished ability to fight the bacterial infection. Phagocytic disorders can be a result of inherited defects of the immune system. Genetic phagocytic disorders can be divided into several groups. These are the defects of neutrophil differentiation or neutropenia, defects of motility, and defects of respiratory burst. Defects of neutrophil differentiation. This occurs when circulating neutrophils are deficient, meaning there are less than 1,000 cells per millimeters. This may be due to different forms of agranulocytosis, cyclic neutropenia, glycogen storage disease type 1b, or failure of release of neutrophils from bone marrow, one version of which is the WHIM syndrome, or the warts, hypogammaglobulinemia, infections, and myelokathesis. This is a rare, dominantly inherited congenital immunodeficiency disorder characterized by chronic neutropenia and cutaneous warts. Neutropenia may be also caused by other immune defects, just like X-linked hyper-IgM, X-linked agammaglobulinemia, or secondary to autoimmunity that accompanies Wiskott-Aldrich syndrome, common variable immunodeficiency, or conditions such as hypersplenism. Defects of mobility. The defect in mobility is manifested as altered chemotaxis, defective random migration, and faulty spreading. Leukocyte adhesion deficiency type 1 results from mutations in the adhesion of molecules on neutrophils, leading to an inability of these cells to leave the circulation. This leads to high peripheral blood leukocyte counts, recurrent bacterial cyanopulmonary and skin infections, and poor wound healing. Defects of respiratory burst. Respiratory burst is a rapid increase in the production of reactive oxygen species during the phagocytosis of microbes. On the other hand, the respiratory burst is an essential component of innate immunity, enabling phagocytic cells to eliminate microbes. So, phagocytic dysfunction include the following conditions: the chronic granulomatous disease, myeloperoxidase deficiency, the Job syndrome, or what they call as hyperimmunoglobulin E syndrome, the Shinya-Higashi syndrome, and the leukocyte adhesion deficiency. So as an overview, let us define the following conditions. First is a chronic granulomatous disease. It is an inherited disorder that occurs when a type of white blood cell or phagocyte that usually helps the body fight infections does not work properly. As a result, the phagocytes can protect the body from bacterial and fungal infections. Next is the myeloperoxidase deficiency. It is an autosomal recessive genetic disorder featuring deficiency, either in quantity or of function, of myeloperoxidase, a peroxidase enzyme expressed by neutrophil granulocytes. Next is the Job syndrome, or the hyperimmunoglobulin syndrome. It is a rare primary immunodeficiency distinguished by the clinical triad of atopic dermatitis, recurrent skin staphylococcal infections, and recurrent pulmonary infections. Next is the Shinya-Higashi syndrome. It is a rare inherited complex immune disorder that usually occurs in childhood, characterized by the reduced pigment in the skin and eyes, immune deficiency with increased susceptibility to infections, and a tendency to bruise and bleed easily. Last is the leukocyte adhesion deficiency. It is a rare autosomal recessive disorder characterized by immunodeficiency resulting in recurrent infection. So, the etiology for phagocytic dysfunctions is primarily because of the mutations in genes that are required for normal neutrophil numbers and functions. But it is also important to remember that secondary phagocytic defects may be also observed in patients with diabetes mellitus, metabolic diseases, or in those with medication-induced neutropenia. So the pathophysiology of Phagocytic dysfunction starts with a defect in the genes that are involved in the phagocyte cell development, cell motility, or respiratory burst. So, when there is a defect in the genes, there will be a defect in the phagocytic system, making it hard to produce effective phagocytes for the body. Then, with that, there will be a decreased number of functional phagocytic cells. With decreased number of functional phagocytic cells, the body cannot initiate normal inflammatory response. By this, the persons with phagocytic dysfunctions are prone to viral or bacterial infections. So the diagnostic and laboratory procedures for phagocytic dysfunctions include history taking. So symptoms are heterogeneous as the organs and systems affected, and it depends on the phagocytic defect. So for cases of neutropenia, severe and early onset bacterial infections are prominent. For patients with chronic granulomatous disease, lymphadenitis, organ abscesses, or pneumonias with typical organisms are common. In chronic granulomatous disease, early onset gastrointestinal disease are not uncommon. Details sought in the clinical history should also include the microbiology of any previous cultures, and also obtaining a detailed family history is always important. Next is the physical examination. So the physical examination should start with the evaluation of signs of systemic illness. Fever may be present with acute infections, otherwise chronic fever will be uncommon. So patients with acute lung infections may be short of breath, have a productive or non-productive cough, and may have pulmonary signs such as rhonchi or rales on examination. Lymphadenitis is also common. Gingivitis, oral ulcers, canker sores, and or swollen gums are common findings in subjects with phagocytic defects. Next is we need to have a CBC with differential count, neutrophil oxidative burst assay, genetic mutational study, an X-ray, a chest X-ray if lung findings are suspected, ultrasound for organ abscesses, CT scan of the abdomen to examine organ size or lymphadenopathy, and MRI may be preferred to minimize exposure to ionizing radiation. So the signs and symptoms of phagocytic dysfunctions are childhood onset of acute or recurrent bacterial or fungal infections, oral ulcers or gingivitis, rectal fistulae, unexplained inflammatory bowel diseases, and organ abscesses. So the complication for phagocytic dysfunction will be death from overwhelming infection. The nursing diagnosis for phagocytic dysfunction will be risk for infection related to compromised host defenses secondary to defect in the phagocytic system. So the goals and outcomes for us nurses would be the patient remains free of infection as evidenced by normal vital signs and absence of signs and symptoms of infection, early recognition of infection to allow for prompt treatment, and that the patient will demonstrate a meticulous hand washing technique. For the nursing management, it is important to assess the presence of local infectious processes in the skin or mucous membranes because these factors represent a break in the body's normal first line of defense and may indicate an infection. Second is to monitor for signs and symptoms of infection because signs and symptoms of infection vary according to the body area involved. Third is to maintain strict asepsis for dressing changes, wound care, intravenous therapy, and catheter handling because aseptic technique decreases the chances of transmitting or spreading pathogens to or between patients, and it also interrupts the chain of infection. Fourth is to wash hands or perform hand hygiene before having contact with the patient. And then next is to place the patient in protective isolation if the patient is at high risk of infection. Medical managements for phagocytic dysfunction would be granulocyte macrophage colony stimulating factor, cell therapy, hematopoietic stem cell transplantation, and prophylactic drug treatment. For the prognosis of the disease, patients with phagocytic defects may do well with medical treatment. So that is all for phagocytic dysfunctions. I hope you have learned something.